In this video, I'll tackle tough questions about progression in multiple sclerosis. If you'd like to better understand progressive disease, don't turn away, because that starts right now. Hey! Howdy! Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel to help my own MS clinic patients learn between visits, and it's my hope that through these videos, I can help you learn too. Today, I'm going to be tackling some tough questions asked by viewers about progression in multiple sclerosis. This is an important topic, and I feel like all too often we shy away from it, and we're not going to do that today. We're going to jump in. HJ asks, what things qualify as disease progression? HJ, that's an awesome question, and we're going to spend several minutes trying to unpack it. For starters, I'd like to introduce several terms that are going to help us in our discussion. The first one is the term worsening. When I say worsening, I mean that your neurological examination isn't as good as it used to be. And so, for example, if you used to be able to do this really fast, and now it's really hard to do it, that's worse than it used to be. We don't know why it's worse. It could be worse because of two reasons. The first one is you suffered a clinical attack and you didn't fully recover. And there's now a term that's been coined to try to describe that called RAW, Relapse Associated Worsening. And so if you had an attack and you didn't fully recover and your exam is worse, then we would say that's associated with that relapse. There's a second reason why you could get worse, and that's worsening on the exam completely independent from attack. This would be what we would refer to as progression. And there's another new term that's been coined, PIRA, progression independent from relapse activity. Now, I didn't make the terms up, but I do find them to be really helpful. And I want you to keep in mind those concepts as I review with you the leaky pool model of MS. Now, I did not create the leaking pool model of MS. My good friend Stephen Krieger at Mount Sinai did. All the credit for this model is 100% his. I am a student of his model and I love it because I think it genuinely helps us understand multiple sclerosis, relapses, progression, the whole kit and caboodle. So what you see on the screen here is a cross-section of a pool. And you see the shallow side and you see the deep end. And you can see the water level, which I've labeled number 1. Now, the water level of the pool in this model is the clinical threshold. Everything above the water level, the human being is aware of and they experience, like I can't see out of my eye or my hand is numb. Everything below the water level, the person's not aware of. It's below the clinical threshold. It'll show up as a spot on the MRI, but the human being doesn't know something happened. Now, the amount of water in the pool, which is represented with that number 2, we refer to as the functional reserve or neurological reserve. The neurological reserve is your nervous system's ability to withstand an insult, not you're ugly, but an insult like you're exhausted, you have a fever, you have an infection, something like that, that is taxing the system. And what you notice is there's less functional reserve, there's less water on the shallow end of the pool as compared to the deep end of the pool. Now, the floor of the pool is a representation of the nervous system, and you see the different colors there. So if you look at that sort of, let's call that salmon color. If you look at the salmon color portion, this is where there's the smallest functional reserve. And that would represent the part of the nervous system that can't withstand very much of an insult, specifically the optic nerves and the spinal cord. The yellow portion, which has more water, more functional reserve than the salmon portion, that's the infratentorium or the brainstem. Now, the brainstem has more functional reserve than the spinal cord and optic nerves, but not very much more. And damage there is probably not going to go unnoticed. If you look at the deep end of the pool, the green section, this is the supratentorium, the lobes, the hemispheres. And this area of the brain has the largest functional reserve. And this is the layout of Stephen's leaking pool model of MS. Now, on the next slide, you see these white stalagmites that are literally pushing up from the bottom of the pool. And some of them go above the clinical threshold, they crest the surface of the water, some of them don't. Both of them represent activity. Activity we define as being a clinical attack or a new spot on the MRI. Now, in this model, if the stalagmite crests the surface of the water and it's above the surface of the water or above the clinical threshold, we call this a clinical attack. So if you look at the salmon color and you see the stalagmite, which I've labeled number 1, this would represent an optic neuritis, and the human being would be aware of it because it's above the surface of the pool. If you now direct your attention to the stalagmite I've labeled number 2, this is below the surface, and so this would be an incidental new spot found on MRI without clinical symptoms. Now, this third picture helps us understand the key to this lecture, which is progression. Remember that the leaking pool model is leaking water. Slowly over time, the water level is dropping. And when I say slowly, I mean over a period of years. And so as you can see in the picture, where the water level was, all of those stalagmites were below the level of the water. And slowly over the years, as the water level drops, it literally uncovers those stalagmites. And as the water level drops and the stalagmites are uncovered, we have a re-emergence of old neurological damage. This is the underpinnings of progression. And we can apply the terms RAW, relapse associated worsening, and we can apply the terms PIRA, progression independent from relapse activity, as we think about the leaking pool. Melanie Parker asks, do we regain functional or neurological reserve? And Melanie, that's a great question. Now, to answer the question, I want to throw up one of Stephen's pictures. We'll use this one, for example. And if you look at the clinical threshold, where that level is, slowly over time, it's going to deplete, slowly over a period of years. But on an hour-to-hour or day-to-day basis, it is a dynamic process. That water level is bobbing up and down. And so to answer your question, I want to think about it in two parts. You can have an impact on your functional reserve, on the amount of water in the pool. You can expend all of it by making yourself exhausted, by having an infection, by getting your body overheated. And in that situation, temporarily, the pool water is going to drop more than you want it to. And in doing so, you might uncover old neurological damage. A very classic example is someone who has suffered an optic neuritis in the past, and their eye is healed, and they've regained a good amount of vision. But when they have a fever and their body heats up, the damaged optic nerve short circuits, and again, they have difficulty with seeing. Once the fever goes away, the vision comes back. This is an example of the dynamic nature of the clinical threshold in the functional reserve. We do believe there are some things that we can do to build up the functional reserve. For example, exercising as part of our lifestyle has been shown to maintain brain volume, and we believe that it's been shown to optimize the functional reserve. Now, at the same time, if you think about it in a different time frame, if you think about it over the period of years or decades, in the setting of MS, the water level is very slowly dropping. There is good evidence from some of the newer MS medicines, the disease-modifying therapies, that we can slow the rate of water loss. In 2019, we can't stop it forever, but it does appear that we can significantly slow it down using disease-modifying therapies. And now for the question of the day. The following are true regarding PPMS. Number 1, no proven treatment. Number 2, doesn't cause enhancing lesions. Number 3, most will need wheelchairs. And number 4, none of the above. Jot down your response and tune in to the end of the lecture to find out the answer. Leslie asks, PPMS, maybe a general explanation of how one finds out what their MS has developed into, which I interpret as, how do you diagnose PPMS? Now, Leslie, I have an entire video on PPMS, and I'll throw a link to it right there. But in brief, I would like to share with you how we diagnose primary progressive MS. First, we look for a year or more of insidious, slow neurological decline. So you're looking at someone who tells you over a period of at least 1 year, they've gotten slowly worse. Their history is not consistent with a discrete event like an attack. It's more of a slow burn. And then, to help confirm the diagnosis, they need two of the following three things. One of them is a brain MRI that has at least one lesion, one spot, which looks classic for MS. The second is a spinal cord MRI that has at least two lesions that look consistent with MS. And number three are unpaired oligoclonal bands on spinal fluid. So, when you have a history of someone who has had a slow, insidious decline in neurological function, which tracks to the central nervous system, and they have two of those three things, that is how we diagnose primary progressive MS. Of course, we also have to prove that it's not anything else that might mimic PPMS, and that's a big component as well. Thanks for the question. Amanda asks, I have RRMS. How do you know you've progressed to SPMS, which I interpret as, how do you diagnose SPMS? And this is not straightforward. I like to use a specific definition put forth by an organization called MS Base. MS Base is a giant database that clinicians can enter their patients into. And it's done a lot of really great work, and I think they probably have the best definition. Now, for starters, you can only diagnose secondary progressive MS by looking backwards, retrospectively. And it'll occur in a human being who has a relapsing form of MS, and they have a history of having had relapses in the past. Now, with that background, we look for the following things. Number one, a year or more of progression of neurological disability, so their exam has gotten worse, independent from an attack or an infection. So at least a year where things have gotten worse on their exam and there's no history of attack. We also have some very specific things that we look for on the neurological examination. The first is that the exam has gotten worse, which has been sustained over at least 3 months. And when you do the EDSS, the Expanded Disability Status Scale, which is the number that we assign to the neuro exam, it's gotten worse by at least 1 point. And so that's a specific thing that we're looking for on the neuro exam. The overall EDSS has to be a 4 or more to fit this definition. And the motor functions have to have a score of 2 or more. Now, I know that's a lot of technical jargon, but I want you to understand that this is a clinically driven diagnosis. It's not a diagnosis based off of some laboratories or some MRIs. It's based off of a clinical history as I've described, and then certain aspects to the neuro exam. I've done several videos on SPMS, and I will throw a link up above to those videos in case you'd like to have a deeper dive exploring SPMS, how it's diagnosed, how it manifests, and how it's treated. So check that out. Starlene asks, how come a person's MRI might show no new lesions or stable MS, but their symptoms such as balance is getting worse? And this can happen in the setting of progression. If you think back to the leaky pool and you imagine that in the past there was a clinical attack, and we would represent that by a stalagmite pushing up through the surface of the water in the area of the brain that controls balance, and that person had difficulty with balance. And then they recovered from their attack. In that case, we would have that white stalagmite drop down below the surface of the water, but it's still there. Over the subsequent years, as the water level drains, as the functional reserve drops, the clinical threshold drops, and it exposes that area of structural damage. And the person can have a re-emergence of old symptoms of difficulty with balance. Another way that I like to describe this is what I sometimes refer to as my shotgun analogy. And I've shared this on other videos, but I'll share it with you right now. Imagine, if you will, that I own a shotgun, which I don't, but let's pretend I have a shotgun, and boom, I blow a hole in the wall. So now there's a giant hole in a wall. And we don't patch it, we just leave it there. Now, as the house ages, as the materials in the house wear out, as the ground settles, which of the walls falls first? It's the one that has the shotgun blast, because the structural damage has weakened the integrity of that wall more than the other walls. This is an analogy that helps me think about what happens when you have structural brain damage from MS attacks and from MS spots. Those areas of the brain are structurally not as intact as they used to be. And as we age, as the brain atrophies, as those areas wear out, this is the underpinnings of progression. Thanks for the question, Starlene. DM Hockey 33 asks, are there any DMTs that treat inactive MS? And I think the answer is yes, although it hasn't been robustly studied. Now, to explain this with you, I'm going to have to make a drawing. So what you see me drawing here is a chart, and on the y-axis going up and down is the neurological examination. So as you go up, you get worse. And on the x-axis going left to right, this is time. So as you go from left to right, you get older. Now, I'm drawing a chart from a clinical trial where we had two different groups of people on two different kinds of MS medicines. And they charted how both groups did over time. And then what they did is they removed the relapses from the chart. So they extracted out any worsening from relapses. And what they were left with is that term I mentioned earlier, PIRA, progression independent from relapse activity. And so what you can see here is how the people did if you remove all the relapses. And what you see is that in both arms, slowly they both got worse. But in the highly active drug, they got less worse. Now, this is really provocative for several reasons. One of them is this trial was done in early relapsing MS, not in progressive MS. And it demonstrates that when you remove the relapse information, there is a subtle underlying progression which is present even early in the disease, which is really kind of mind-boggling. The second thing is, yes, if you remove relapse activity, drugs still have an impact on slowing progression, and it looks like some drugs do it better than others. This is a very, very important point. In DM Hockey 33, I'm really glad you asked the question. And now for coffee. Hey! Bonnie S. asks, what advice would you give for someone diagnosed with secondary progressive MS with increasing disability, trying hard to keep walking? Bonnie, keep working at it. That's awesome. And this is something that is treatable. Yes, we can treat secondary progressive MS. And really, there's a three-pronged approach. There's three different avenues for treatment, and I want us to do all three. The first one is to take a disease-modifying therapy, because yes, disease-modifying therapies slow progression. As I just shared with you in the last question, some do it better than others. The second is we want to use symptomatic medicines to help with symptoms. So for example, if part of the reason you're having trouble walking is worsening spasticity, spasticity medicines to loosen your legs will help. If part of the problem is that you have heat sensitivity and motor fatigue, using a medicine like PIRA to buttress against heat sensitivity will help. A third very important prong to consider, or approach, is physical therapy and rehabilitation to optimize your body and to minimize deconditioning. And so, for example, a stretching regimen, a strengthening regimen for your legs, and pelvic floor physical therapy could do wonders. Bonnie, we're not done yet, and keep fighting. Consider these three prongs to optimize your situation despite having secondary progressive MS. Tamara asks, weird question from probably a depressed patient, but can we still walk and talk after 40 years living with MS? Tamara, I don't think that's a weird question. I think that it's a question that's on almost everyone's mind. And what I'm showing you here is called the PDSS. It's the patient-determined disease step. It's a collection of disability on the x-axis, so going from left to right, where on the far left, 0 is normal, no neurological disability, and on the far right is 8, bedbound. And on the y-axis, going up and down, you have years of time that someone's had MS. So 0 going all the way down to 45. And what you see is the colors. And people tend to stay on their color. And so let's use the example of the red color, where someone in the first year of their disease is having gait difficulties. They're not using a cane yet, but they're having difficulties with gait. Now, if you follow the red as it moves down, you see that it's moving from left to right. And you can see that no point does the person in the red ever enter 7, which is a wheelchair? And my point in sharing this graph with you is that you are not doomed to end up in a wheelchair or in a bed just because you have MS. Now, I also want to point out that we can impact this graph by taking disease-modifying therapies. And so we can shift the graph, or we can keep you in that column longer, hopefully very long time, by taking disease-modifying therapies. The short answer to your question is that no, it is not a foregone conclusion that if you have MS for 40 years, you're going to end up unable to walk or talk. And as you can see in this graph, the vast majority of people don't end up like that at all. And now to answer the question of the day. The following are true regarding PPMS. The correct answer is number 4. None of the above are true. There are proven treatments to slow PPMS. MS causes enhancing lesions, and we see enhancing lesions in the setting of PPMS. In fact, when you do a clinical trial of people with primary progressive MS, a fourth of them have enhancing lesions on their brain MRI at the time of enrollment. Most end up in wheelchairs is also false. Based on the graph I showed you in the question before, the vast majority do not end up in wheelchairs. Did you get the answer right? Hey Village! What questions about progression have you not yet had answered? Please leave those questions in the comments section below. I look forward to reading them, and I will answer them in an upcoming live stream or video, just like this one. Thanks for learning about MS with me, Aaron Boster. If you would like to learn more about primary progressive MS, check out this video right there. If you have questions about secondary progressive MS, check out this video right there. And if you haven't yet subscribed to my channel, please consider doing so. Just click the circle with my face in it. Go ahead, click my face. Until my next video, or my next live stream, or the next time I see you in clinic, this is Aaron Boster saying take care.